And I'm wondering if Professor Graham Stuart, who's our next speaker, is actually available now. Is he here?
Hi, Anne. Yes, I'm here. Can you hear me?
Oh, Graham, marvelous. How are you?
Very well, thank you.
Good. Thank you for joining us. Graham's been very busy this week. He's already given 3 lectures, and this is his 4th. He's trying to retire, but it doesn't work, does it, Graham?
It doesn't, as you well know.
Professor Graham is an outstanding cardiologist based in Bristol, faithful advisor to the Marfan Trust and the Marfan Association. Most recently has served on the management committee of the AIMS trial, which stands for Aortic Irbesartan in Marfan Syndrome. And we were in the UK mounting this trial to see if we had found a better use for an already recognized and approved medication in keeping the aorta strong. We think we found statistically significant results, so we're busy trying to popularize this. And so Graham's going to tell us why we think it's better and how the patients get their hands on it, because some of the cardiologists are a bit resistant to new medication. Graham, can you tell us all about it?
Thank you very much for this invitation to talk at this meeting. It's very exciting for me, and particularly it's exciting to see a merging of the Marfan Association UK and the Marfan Trust. As Anne said, I had the great privilege of serving on the medical advisory group for Marfan Association, and it's wonderful to see both organisations coming together to support patients and families with Marfan syndrome. And on behalf of the profession, I would like to thank the patients' organisations because they're extremely useful for doctors who are working in this field. My task is to talk about the condition first described by this fellow. This is Antoine Marfan, who was a French paediatrician. And way back in 1896, he wrote a case report on a young girl called Gabrielle, who had rather long, elegant fingers, had some contractures, and that condition eventually became known as Marfan Syndrome. My specific job is to take you through some of the results, and they're fairly technical results, of the AIMS trial, which is the Aortic Irbesartan Marfan study trial, where we used Irbesartan to try to prevent some of the aortic complications in Marfan syndrome. And to answer the question, is it better and how do we obtain it? I'd like to start off with my personal history. This is a picture of me when I first became a consultant. Well, maybe it's not quite a picture of me, but this is when I went down to Cardiff in 1993. I was from Glasgow, and it was a bit of a trek and a cultural shift to go and work amongst the Welsh. I knew what Welshmen looked like, so I'd seen them playing rugby, and I was slightly intimidated. But shortly after arriving, I met this lovely lady, Sally Davis, a clinical geneticist who had a particular interest in Marfan syndrome, and Sally has retired now. But on day 1 that I arrived, she came up to me and said, Professor Harper, who was the professor of genetics, wants us to set up a Marfan clinic. And between 1993 and now, some very, very exciting innovations have developed in Marfan syndrome, and Professor Pepper's told you already about some of the surgical innovations. This is where I work, in Bristol Children's Hospital and the Bristol Heart Institute. I work with children and adults with arrhythmias, and also lead the Inherited Cardiac Condition Service, which is where our Marfan syndrome clinic lies. And I have a particular interest in exercise, research, and that's of benefit to virtually all cardiac patients, including those with Marfan syndrome. So, Irbesartan in Marfan syndrome and the AIM study. Well, in order to take you into this, I'm going to give you a little bit of a history lesson as to how we've learned about Marfan syndrome in the last 20, 30 years. I'm to mention very briefly how we make that diagnosis, and then talk a little bit about some of the treatments of Marfan syndrome, and specifically the Irbesartan treatment, to address the question, is it better and how do we obtain it? History lesson. History is of great value in so many different ways. I wish our politicians would read a little bit more of it. So from the Marfan research over the last 100 years, we know that Marfan syndrome occurs in round about 1 in 5,000 people. It's autosomal dominant, which means it affects men and women equally. and is inherited in a 1:2 inheritance ratio. And it affects predominantly the skeleton, the eyes, and the cardiovascular system. And everybody here knows that. From a cardiologist standpoint, the most important cardiac abnormality, although there are multiple ones, as Professor Pepper has just been talking about, the mitral valve and so on, but the main issue is this enlargement of the aorta. This cartoon shows the heart here. This is the aortic merit of the heart, and this is an enlarged aorta. And that can cause troublesome symptoms, but more importantly, can lead to a potentially life-threatening complication if that blood vessel becomes fragile and tears, an aortic dissection. 1986, there was the discovery of this substance, fibrillin. This is a glycoprotein, and it's incorporated into things called microfibrils, which are ubiquitous throughout the body. And fibrillin is really important, and we know that because it's found in the most simple of creatures. So, for example, the jellyfish, which is one of the evolutionarily longest existing organisms, it's present, fibrillin is present in the jellyfish. So that suggests it's of ontological importance. It's found in microfibrils, and microfibrils are scattered throughout the body and in most of the tissues affected in patients with Marfan syndrome. And from a cardiovascular point of view, particularly in the blood vessels, in the heart muscle, and in the heart valves. In 1990, it was noted that patients with Marfan syndrome have abnormalities of fibrillin. And the same year, it was found that fibrillin was, Marfan syndrome, sorry, was linked to chromosome 15. And it started to get a pattern as to why Marfan syndrome was developing and how it developed. 1991, the fibrillin gene was linked to chromosome 15. So all started to come together. Marfan syndrome was associated with an abnormality in chromosome 15, and so was fibrillin. Clearly, an abnormality in fibrillin had a prime importance in this situation. And that led to this hypothesis, which was present for many years. That is, if you have a deletion in chromosome 15, half your cells, that leads to abnormalities of fibrillin, leads to abnormal microfibrils, that leads to abnormal elastic tissue, and leads to the features of Marfan syndrome. That's the so-called dominant negative. So that was the history lesson up until just a few years ago. That led to us producing various criteria for diagnosing Marfan syndrome. This was put together in a paper in 2010 called the Revised Ghent Nosology. And basically what it said was that you take family information, if there's a family history of Marfan syndrome, you take genetic information, and you take clinical information, and putting all that together using various criteria, you can then make the firm diagnosis of Marfan syndrome. So that's how we diagnose it. That was some of the genetic and histological backgrounds to Marfan syndrome. And that led to a variety of different treatments. And this character, this is the American barnyard turkey. And this was the first important bit of knowledge that led us to know how to treat Marfan syndrome, or so we thought. And this is because if you're an American turkey farmer, they've known for years that turkeys have a tendency to dissect their aortas. And if you put beta blockers in the turkey feed, few of them dissect their aortas. And Victor McCusick, who is a very famous professor of genetics in Johns Hopkins, started using beta blockers in patients with Marfan syndrome. And this is way back in the late 70s, early 80s. It wasn't until 1994 that a randomized controlled trial, which is a standard way of assessing medication in the treatment of a condition, was carried out using beta blockers. This was a tiny trial by modern standards. Only 32 patients with Marfan syndromes were put on the drug, compared to 38 controls. They were adolescents, they were followed up for 10 years, and you found that there was a reduced rate of the aorta dilating, of aortic dissection, and indeed of sudden death in the patients put on beta blockers. And this was very encouraging, and from the first time gave us some evidence to suggest that beta blockers might be effective. An important feature was that the two patients that died in the control group, they didn't have a dissection, suggesting that it may be that they had an abnormal rhythm, and perhaps one of the methods that beta blockers are helpful is not just through the aorta dilatation, but also reducing the likelihood of abnormal rhythms. And I may come back to that. The problem with beta blockers is that they've got a lot of side effects. In this country, about 15% of children have asthma, and beta blockers make asthma worse. Moreover, as any of you know, when you first go on beta blockers particularly, that can make you very tired and a bit lethargic, and that led to poor patient compliance. Some people just could not tolerate being on beta blockers. And then as time went on, it became clear that they weren't all that effective in everybody. So this suggests that in some, this was actually children, they may not be effective, or in fact, they can increase the stiffness of aorta. So although we were all using beta blockers, it became clear that they weren't a panacea, they didn't help absolutely everybody. And around about 2007, 2008, there was a lot of criticism of the use of beta blockers. This was a meta-analysis published in the International Journal of Cardiology, looking at 802 patients in non-randomized controlled trials predominantly. And they concluded, using very complex statistical methods, that beta blockers had no significant benefit. And that led to the publication of an editorial dealing with the results from that meta-analysis, pointing out that the meta-analysis used non-randomized studies. In other words, the science on which they made their analysis was not very good. There were lots of different doses, lots of different patient substrates, and effectively they were comparing apples with oranges. And so the conclusion that beta blockers were no use really wasn't a valid conclusion. And that's one of the reasons why we continue to use them. So the editorial writers concluded that until more data is available, we should not stop prescribing beta blockers. What about the other drugs that have been used? Well, there's drugs, calcium antagonists such as verapamil. Not very much information, very small patient numbers, and really there's no evidence that that's of benefit specifically in preventing aortic dilatation. What about angiotensin converting enzyme inhibitors? Now, they may be used in Marfan syndrome for several reasons, but in terms of reducing aortic dilatation, very few studies, and again, no real evidence that they're of benefit. What about matrix metalloproteinase inhibitors? These have been used for many years in abdominal aortic aneurysms, and they have some theoretical benefits. They reduce elastin degradation. They can prevent abdominal aortic dissection and rupture. But really, again, no evidence in the ascending aorta in Marfan patients. So that led to this whole concept of transforming growth factor beta inhibition. And I apologize for all this jargon, but let me explain what that is. Here you've got a cartoon showing basically the outline of the cell wall, the vascular wall. And here you've got the cell matrix, and here you've got the microfibrils. And within the microfibrils, this is fibrillin, this long supportive scaffolding type structure. Right beside the fibrillin, you've got this stuff here, which is transforming growth factor beta binding protein. And transforming growth factor beta is a protein, a cytokine that's produced in response in many different tissues in response to things like inflammation. This binding protein lies very close to fibrillin. And in patients with aortopathy or with aortic dissection, it was known that transforming growth factor beta was elevated, which led to people thinking maybe a disrupted fibrillin leads to disruption of the TGF binding protein, leads to too much TGF-beta, and that produces the features of Marfan syndrome. And so that led to this hypothesis. Hal Dietz was the first person really to put this together. Could Marfan syndrome be due to overexpression of this TGF-beta substance? And this led to the use of the famous Marfan mouse. This is a so-called knockout mouse where they take the equivalent of chromosome 15 Marfan gene, knock it out in the mouse, and you end up with a very tall mouse with long, elegant fingers, but also the spinal problems and the aortic problems and the mitral valve problems that you get in Marfan syndrome. And it was a real eureka moment when they found that if you give an antibody to this substance TGF-beta, then the Marfan mouse develops no features of Marfan syndrome, provided it's given to the newborn Marfan mouse. And these are some pictures taken from Habashi's paper. So this is a normal mouse. This is the aorta in the normal mouse. This is sorry, I beg your pardon, this is the aorta in the Marfan mouse. This is the aorta in the normal mouse. So they see the Marfan mouse has a much bigger aorta. This is the aorta into the newborn mouse given beta blockers. It really is very different from the placebo. And this is the aorta in the Marfan mouse given losartan. You cannot give an antibody to TGF-beta to a human, but you can give losartan. And losartan is an angiotensin receptor blocker that was designed for treatment of high blood pressure. And it has a side effect of affecting TGF-beta production. So they then discovered from this mouse study that actually giving losartan to the Marfan mouse prevented the aortic complications in the same way that giving an antibody to TGF-beta. Very, very exciting science. And this was another paper by Hal Dietz showing some of the mechanisms whereby losartan seems to affect this angiotensin receptor and prevent some of these features. And that's led to a whole series of studies, including the AIM study, to try and see if by giving the same drug of angiotensin receptor blockade will prevent the aortic complications of Marfan syndrome. The first such paper was in the infantile Marfan patients. Professor Pepper mentioned earlier, this is a specific genetic change within the fibrillin gene, and it produces quite a serious form of Marfan syndrome. This is little Chloe, an old friend of mine, who had the neonatal form of Marfan syndrome. The very first paper looking at angiotensin receptor blockade was in that group of severely affected children with a nasty form of neonatal Marfan syndrome. And they gave them losartan for 12 to 47 months and found that the aortic dilatation reduced. Very small numbers published in the New England Journal of Medicine, but that was encouragement, thinking that maybe these ARBs will be of benefit. It certainly seemed to show slow progression of aortic root dilatation. And that led to a whole series of ongoing studies. There was one published from the United Kingdom. I'll be talking about the AIM study. There's one in Italy, there's one in Holland also, a number of these different studies, all looking at ARBs. So the British study was to investigate whether the angiotensin receptor antagonist Irbesartan reduces the rate of aortic dilatation in Marfan syndrome compared to placebo. And one of the reasons we chose Irbesartan was for the chemical characteristics where it is what's called better bioavailability. More of the active drug is available for the body to use than, for example, losartan. So this is, I'm going to take you through some slides which Mike Mullen, who led the study initially, presented to the European Society of Cardiology about 2 years ago now, in fact, before the study was published. He went through the evidence that angiotensin receptor blockade demonstrates prevention of aortic dilatation, talked a little bit about the mechanism whereby it modulates abnormal TGF-beta activity, and the observational data in the initial studies in children in the New England Journal, where it suggested that it could be effective in preventing, in a small number of severely affected children, preventing aortic dilatation. So Irbesartan was chosen at a longer half-life, better bioavailability. 22 centres in the United Kingdom took part, and many of the people here, I'm sure, have been taking part in that AIM study, sponsored by the Royal Brompton Hospital, and with support from the Marfan Trust and from Marfan Association. All the echocardiography was carried out locally, but the core lab was by Dr. Zujin in the University of Oxford, where they remeasured everything. So it was all done by the one group to reduce intra-operator error. Patients were over 6 and under 40. They all had to have clinically confirmed Marfan syndrome according to that revised Ghent criteria, and obviously they all gave consent. The people that couldn't enter the study were those where surgery was planned or they'd already had it, where they didn't have any aortic dilatation, and a Z-score is a standard deviation score, where the aorta was at such a level that surgery was likely to be imminent, or where they had severe valve disease or heart failure, or for some reason couldn't take ACE inhibitors. And also in ladies who were planning to become pregnant. Taking you very quickly through the the study design. So basically, everybody went on this Irbesartan in a low dose, first of all, to see if they had any side effects from it. And then they were kept on it for up to a total of 60 months. And echoes were carried out every single year, as well as a variety of other tests. And they were allowed to keep on beta blockers if they were already on them, but they weren't added as part of the study. And the main endpoint was looking at aortic root diameter, but also change in standard deviation score. In other words, for children particularly, obviously they grow, but it was the change in aortic size relative to their size. And these were how the aortic root was measured, all in a standard way by Zujin in Oxford. And taking through to the graphs, this shows the difference in aortic root diameter over the period of follow-up. So the red line represents Irbesartan patients, and the blue line, the placebo group. So clearly there was less aortic dilatation in the Irbesartan than in the placebo group. Similarly, the Z scores were reduced in the Irbesartan group compared to the placebo group. And there was fairly complex statistics put in to assess that. This shows that perhaps one of the main reasons for this is that the blood pressure was under better control. So the blood pressure in the Irbesartan group was significantly less than in the placebo group. I'll skip past the statistics. Anybody that wishes to read these, the paper was published in the Lancet and it's open access, so it gives details of the precise statistics. One of the important features is that the medicine was very well tolerated. Even in the 6-year-olds, very, very few patients couldn't continue the study because of side effects. And this is a significant adverse events. There were really no difference between the placebo group and Irbesartan. In other words, the Irbesartan didn't cause any nasty side effects or adverse events. These were the centres which took part. I have to boast about the Bristol Centre because we had a lot of patients. But overall recruitment was perhaps slightly disappointing, and that wasn't the patient's fault. It was largely the clinician's fault, because setting up these studies is extremely time consuming and it requires an awful lot of organisation. But we were delighted that 22 different centres contributed. So the paper was eventually published just under a year ago in the Lancet. As I say, it's open access, and these slides will be available for you. If you type that into Google, then you can get a copy of the paper. And the conclusion of that paper was that Irbesartan is associated with a reduction in the rate of aortic dilatation in children and young adults, and could reduce the rate of aortic complications. So a very, very exciting finding. So the question, is it better? Was it better than existing treatments? Well, the evidence for existing treatments is not great in terms of scientific literature, although in terms of treatment of patients, I think we would all feel that beta blockers do have a certain role to play. Secondly, how do we obtain it? And thirdly, how should we use it? Is it better? Well, scientifically, we don't know yet. We will have to monitor patients for much, much longer. And that's a long-term 20-year study, really. Importantly, there's very few side effects. And importantly, it does seem to have better bioavailability than the other angiotensin receptor blockers, such as losartan. Whether that's clinically important, we do not yet know. Secondly, how do we obtain it? Well, the beauty of this medication is that it's an easily available, cheap drug that's been in use for many years as an antihypertensive for treating blood pressure, high blood pressure. So there's no difficulty in doctors prescribing it if you can get your doctor to prescribe it. How should we use it? Well, we don't know. So I'm going to give you my approach, not the Rod Stewart approach, the Graham Stewart approach. And that's just one man's opinion, but this is what I do in practice with my patients. First of all, I will use Irbesartan in most children and adults with Marfan syndrome. My default is to use it, not to not use it. And specifically, if the aorta is enlarged, which it is in at least 80% of people with Marfan syndrome, or if it's growing more rapidly than somatic growth, particularly in children. Secondly, I will use it as sole therapy on its own if for any reason beta blockers cannot be used because of asthma, because of side effects. But I'll have a very low threshold for using it with beta blockers because they seem to act in a different way, and particularly if the aorta is enlarging rapidly, or if for various reasons there's thought to be a high risk of dissection, bearing in mind that beta blockers may also have a role in preventing arrhythmias, and that that's something that hasn't really been teased out in the scientific literature yet. And also, just because you've had an operation doesn't mean you can come off these medical treatments, beta blockers and or Irbesartan, even after aortic surgery, because the descending aorta can dilate and you develop a tear. So if your ascending aorta has been replaced, I wouldn't stop all these medications. So that's the Stuart approach. I just leave you with an intriguing finding that I've found is that since these very first papers came out in 2007, I've been using actually losartan, which is the first paper, in infantile Marfan syndrome. And what used to be so terrible is, as John Pepper mentioned earlier, is they get severe heart disease, but also they get severe spine disease that leads to lung abnormalities. And in infants started right from the word go on an angiotensin receptor blocker, they have not had the severe spinal disease that we've used to see so commonly that could even be fatal in itself. And it may be that these angiotensin receptor blockers have a role to play in preventing some of the severe spinal problems that can develop. And that's not been proven, but that's my personal experience. So very rapid run through AIMS trial results, Irbesartan and Marfan syndrome. I've tried to at least address some of the question, is it better and how do we obtain it? And I'll open up now to any questions. Thank you.
Thank you very, very much, Graham. I think you've answered most of our questions, but I just wanted to tackle the problem of arrhythmia. If a lot of pediatric cardiologists want to start the trial on beta blocker, no matter what, can Irbesartan be added safely? Are there any interactions? And if you don't use beta blocker, do you think you're missing treatment for possible arrhythmias just with Irbesartan?
Well, can they be added? Yes, they can. The one thing you have to be a little bit cautious of is blood pressure. And if somebody has a low blood pressure, if you add in a beta blocker, add in Irbesartan, in theory, the blood pressure could go down further. Although one of the very useful characteristics of Irbesartan, although it's an antihypertensive, it tends to reduce blood pressure more in people who have a high blood pressure rather than people who have a normal blood pressure. So it doesn't reduce the blood pressure quite as much as you might expect. So yes, it can be added. There's no significant interactions. The question about arrhythmias is a complex one, and we don't know the answer. I carry out 24-hour ECGs in patients with Marfan syndrome, even if they don't have symptoms of palpitations, because I am concerned that some patients, often if they've got mitral valve prolapse, in fact, will have arrhythmias that may not be being protected by the Irbesartan on its own. So I would have a low threshold for adding in a beta blocker. And I suspect if we had all the money in the world and all the time in the world, doing a randomized controlled trial of ARB versus ARB and beta blockers would be a very interesting way of proving that. In practice, that I don't think is going to happen. So I do have a concern about it. And any symptoms, I'd add in beta blockers, definitely.
Thank you very much. Victoria is saving a very nice question for you.
It's actually brimming with questions, the chat function here. The first is from Lisa, who wants to know if valsartan is as effective as losartan. She had severe back pain whilst on losartan and other drugs in the group. Valsartan is the only one of the group she can tolerate.
Right, I mean, this does seem to be a class benefit. In other words, the sartan drugs, the angiotensin receptor blockers, they all seem to have a benefit. There have only really been trials, I'm not aware of any trials ongoing with valsartan, but in theory, it should be as effective. I don't know about the bioavailability of valsartan compared to Irbesartan, but we know that losartan can be helpful and effective. So I would not have any concern about being on valsartan. Certainly, if you have side effects from the others and it works, I would go with it.
Thank you. And what of the benefit of this group of drugs after aortic surgery?
I would certainly remain on it because the aortic surgery removes the high risk area but the whole of the aorta is affected. And I've had a number of patients over the years who, despite having their ascending aorta repaired, have developed a descending aorta tear. And the hope would be that you'll prevent that from happening. Again, we don't know that in terms of long-term studies, but I think it's likely. So I would certainly keep that on. And you want to maintain a controlled blood pressure post-surgery as well. So that's helpful in that.
Thank you. A lady whose daughter is 18 and on Candesartan, should she push for Irbesartan?
No, I wouldn't. I mean, we used Irbesartan for theoretical reasons and it seems to work. Candesartan may well have the same effect. Same answer really as to the valsartan answer. It does seem to be a class effect of the ARBs in being beneficial.
And a last question, Victoria, and then I think we have to break for coffee.
If losartan and Irbesartan are very similar but have slightly different effects, we're not clear yet as to which is most effective. Could patients not be prescribed both?
Not really, because that would be like giving a double dose of one. So they work in the same way. I'm trying to think of an analogy, but it would be they won't have an added benefit. Whether different classes of drugs like beta blockers and sartan drugs would be a benefit. Personally, I think they probably do have an added benefit, but that remains to be proven.
Thank you very much, all participants. We're going to have a quick coffee break now from 11:20 till 11:40. And if I could see you back then, that would be lovely. We're going to hear Mr. Chandra talk about eye problems. And then one more speaker, Dr. Ergon Martin, talking about research in the laboratory. So see you in 20 minutes.
Victoria?
Yes. Yes,
Hi.
Mr. McGreevy.
Yes, speaking.
Hello.
A question to the previous doctor. To get a question to him. Does losartan cause breathing difficulties?
Or respiratory issues?
I'm here with my wife. We'll show you.
Bottom line is no, it doesn't. It's not recognised to do that. And certainly in our study, there were no patients who had breathing difficulties. Breathing difficulties can occur in Marfan syndrome, but losartan or Irbesartan are not recognised as causing that. So it's more likely to be due to something else.
So are they recognised as exacerbating any scoliosis at all?
No, they're not. And in fact, my experience is that in the neonatal form of Marfan syndrome, it used to be scoliosis was very, very severe, and young children would sometimes not make it to adult life simply because of the effect of the scoliosis on lung function. And so it's just been an observation, because it's an extremely rare condition, the neonatal Marfan syndrome, but in the 6 or 7 patients we've had in the last 10 or 15 years, none of them have had very severe scoliosis. And that I found remarkable. And they've all gone on an angiotensin receptor blocker from infancy, more or less from birth. So I think it's likely to be of benefit, but there's certainly no evidence it will cause harm.
Thank you. We just keep going around the same circle with our daughter on respiratory issues, unfortunately.
Yeah, I mean, you can get specific changes in the lung. You can get, there is fibrillin in the lung, and you can get a thing called emphysema, where the lung forms little blisters. That can cause respiratory issues, as can scoliosis. So a respiratory, I don't know how old your daughter is, but a respiratory pediatrician or physician should really be involved if these are problematic.
Yeah, so we have a respiratory doctor and a scoliosis doctor. Aurelia is 11, and the typical instinctive reaction of most of the doctors that aren't covering scoliosis or pectus seems to be that it's architectural, because there aren't really any signs of, I think it's called bully, if I'm correct, as the language. But whenever we then speak with her scoliosis and pectus doctors, they say that the scoliosis is not causing respiratory issue, and there's no evidence to suggest that operating improves lung function.
Has your daughter had a cardiopulmonary exercise test where she runs on a treadmill where they measure both the heart rate and also where she wears a mask, and they measure the lung function on exercise?
She has, and she's had a lung capacity test. So her capacity relative to her normal capacity at her age is down to 40%.
Right. So I think what they're probably saying is that they can't exclude the reason being for the poor lung function being either the scoliosis or the pectus, but whether or not a surgical intervention will help is the question. And certainly we've had patients who've had very severe pectus abnormality where they've had a lot of lung, in fact, they've even had cardiac compression where the pectus surgery has been carried out. But that's difficult in a young child because often, prior to puberty, the sternum, the breastbone is not really fully ossified. It's not really bone. It's much more flexible. So surgery doesn't always help it.
Is there any evidence to suggest that whilst scoliosis or pectus operations may not mean that the lungs can recover, that the operations prevent further deterioration?
I don't know of evidence. I mean, I know that there's two issues here. One is the developing, growing child, and the other is the adult who's going to, where everything is developed. And I think that they are two very different issues because intervening in a child where things are changing is much more difficult than intervening in an adult where things are static. And so there isn't evidence that I'm aware of, although the respiratory team might be aware of that. I'm sorry, I realise that doesn't really answer your question, but I'm not aware of the answer to that.
No, it's fascinating. It's been really helpful talking to you, and the presentation that you just gave from our perspective was fascinating. So thank you.
Thank you. You're welcome.
Mr. Stuart, may I just introduce you to a lady called Anna Jones, hoped to ask a question earlier. Would you mind? I'm grateful for this. Thank you. Anna, if you'd like to.
Thank you, Victoria. Thank you, Mr. Stuart. I wanted to ask specifically about side effects of Irbesartan and particularly in relation to the liver, because I was on the trial and I'm very aware that kind of kidney function was monitored during the trial. And at the end of the trial, I'm on Irbesartan now and I'm fine, but my son was put on it and it affected his liver, caused inflammation and scarring. And that was actually picked up by accident because our GP threw in a liver function test at the same time as the kidney test rather than it necessarily being recommended. And the cardiologist was surprised to find an effect on the liver. And I just wanted to ask you about that, please.
Yeah, so well, we didn't see any significant liver effects in the AIMS trial, and it's not generally recognised as being a side effect of Irbesartan. Any drug can have an idiosyncratic reaction in any individual. So in other words, individuals can have their own specific reaction to a drug, or it could be that something else affected the liver, like he had a mild hepatitis that he was unaware of.
Oh no, we've been through a
lot of tests on that. So I guess that must have been an idiosyncratic reaction, but it's certainly not a recognised reaction. It's not something that everybody gets. Some drugs always affect the liver in everybody to varying extent. Irbesartan is not one of these.
Thank you. I appreciate that. I know that's the case. I wasn't sure if it was a thing that had been monitored during the trial, so thank you for clarifying.
Mohammed wanted to know which arrhythmias you would be worried about in Marfan patients specifically.
Well, I mean, worry, I would not wish any patient to have symptoms. So if somebody's having an abnormal rhythm which is upsetting them, then you might want to treat it. Or if they had an abnormal rhythm which they may or may not feel, but which was likely to be dangerous. And by and large, the ones that can sometimes be upsetting but tend not to be dangerous are the ones in the top chambers. The ones that would be more of a concern, the ones that potentially might be dangerous, are the ones in the bottom chambers. So that's one of the reasons why I do 24-hour tapes from time to time, and not, you know, every couple of years perhaps, even in an asymptomatic patient, because I'd want to just make sure they weren't having runs of fast rhythm from the bottom chambers.
Thank you, Doctor.
And Ruth would like to know if are there any potential complications with cataract surgery and Marfan syndrome? In the context of betablocker?
Not that I'm aware of. So, I mean, a number of patients with Marfan syndrome under my care have had cataract surgery. They haven't had any more problems than anybody else. I'm not really qualified to answer that one, but I'm not aware of any complications.
Thank you very much. Thank you. I'm just scanning because it was just filling with questions.
There was a question about Z-scores. I'm sorry, I skated over that. A Z-score is basically a standard deviation score. So if you have 100 people at either end, the sort of 5% at either end, that would give you your standard deviation. So plus or minus 2 Z-scores is more or less plus 95% of that 100 group of people will be within 2 Z-scores. So it's a way of linking aortic size to growth, or to the normal size of a patient. Obviously, Marfan patients tend to be tall, and so if you're 10 and you have an aorta of say 29 millimeters, that might be very big if you're a short person, but if you're a tall person with Marfan syndrome, it may be within the normal range for your height. So that's why we use Z-scores.
Excellent, thank you for clarifying. Have I left anything lingering? I think that's
Victoria.
Question. Oh, sorry.
Sorry, Victoria. Sorry, I have a question for you. We have to nip out shortly, but we are returning as soon as we can.
Yes.
I noticed this is being recorded. Bits that we're missing, can we access them over the weekend or the following week? Would that be possible?
I think so. Yes, we're recording it, and we're going to probably treat it in sort of chunks without these tea and coffee breaks. So yes, we can send you anything you've missed, and to any of these other participants fairly imminently.
Okay, that's great. Well, yeah, we just don't want to miss anything. Unfortunately, we have to head out for a couple of hours, so with the children. So, but we'll be back later on. Thank you very much.
Thank you. Bye bye.
Hello.
Bridget, hello.
Hello. Hello. I just would like to say hello to Dr. Graham Stuart, and thank you for all your lovely talks and everything. I don't know if you remember me, because you diagnosed 2 of my children. And I
do remember you, and I just saw your name on there. I've just been looking through some of the names. I recognise a few names. Yeah, it's lovely to see you again.
And you too. And I worked with this man as well. He won't remember that, when I was a cardiac scrub nurse. But going back to losartan and irbesartan, 2 of my grown-up children were on that trial, and they've both been put on losartan. But if irbesartan is the better one, why have they gone on losartan?
Honestly, probably because the cardiologist is more familiar with losartan, but the American trial used losartan, and the results were not as clear as the irbesartan trial. So that's why I use irbesartan. And in theory, it's better. There's no difference in terms of side effects or anything like that. But it's the way to deal with that is to show the consultant the Lancet paper, and that makes it fairly clear the benefit of irbesartan. And it's not a huge benefit, but it's only a short-term, relatively short-term paper rather. But it's probably just the consultant's more familiar with losartan. That may be as effective, but what evidence we have got suggests that Irbesartan is better.
Lovely. Okay. Thank you very much. Very nice to see you again.
You too.
Graham, can I ask you a question? Because we have parents contacting us who want their children on Irbesartan, but the cardiologist insists on putting them on losartan, as you say, because they're more familiar with it. And yet the parents, some of them have been on the trial and they know it's better. How can they approach their cardiologist politely and ask if their child could be switched or placed on Irbesartan?
I would give them a copy of the paper. Probably the pediatric cardiologists are probably relatively unfamiliar with Irbesartan. It's not a drug that's used for anything else really in pediatrics. So with leaky valves and so on, you would use losartan. And most of these drugs do not have any, there's not a huge experience in children. So people use what they're familiar with. But so under the age of 6, for example, I will also use losartan because I know exactly the right dose to use in an infant, for example, of losartan. But the AIM study used it without any problems at all in 6-year-olds and above. So certainly school-age children, I think, can be on Irbesartan. Again, just share the paper with the pediatric cardiologist, and most doctors will listen to you, and if they don't, well, you maybe have to be more firm, but it's a difficult one. How to change a doctor's mind? I think a good doctor will listen to their patients, and more of us are aware of the concept of the expert patient. Particularly in a condition like this, people who are interested in Marfan syndrome, you may find out that you know a little bit more about your condition than the doctors who you're seeing if they're not specialists, and that's a difficult one. But the NHS recognises the concept of the expert patient. Show them literature from the Marfan Trust. Most doctors will come round to it, I think, in the end.
I will start distributing copies of the paper then.
Yes.
Any other questions? Can I also ask one again, Graham? We had a couple of twins on our study, our AIMS trial study, and one was on placebo with no effect, and the other one was on Irbesartan. Now, when the results came out, the mother clearly wanted to know which child was on which, so that she could then request that the placebo child be put on Irbesartan. But the cardiologist in question would not tell the parents. What do you think about the ethics of that?
Gosh, I mean, some doctors are very possessive about these things. I'm a great believer in openness. I cannot see any harm in doing that. In fact, it would be very interesting to know. I mean, if I was a parent, I would want to know. And,
exactly, yes, yes.
Doctors are a funny bunch, as we all know. I don't think that's an unreasonable request. It's very difficult if the doctor refuses. Do patients have a right to know? Well, probably. I don't know if they have a legal right. They've certainly got a moral right, I would say.
One patient said to me once, I don't like the doctor knowing something that I don't know about me. Well, and I thought, that sounds very fair to me. Yes.
Yeah, absolutely.
Victoria, did you have any questions stored up, or have you used them all?
I think I've exhausted them all. I think I have. I'm just frantically scanning the chat, but nothing's been left
no more questions.
unattended.
No, jolly good.
Good.
Is everybody enjoying the morning?
Yes, we are. We are.
Yeah, good.
Sorry,
Right.
Victoria, I think Paul has a question.
I have a question too.
Carry on. Who's first?
Well, Paul, go ahead.
Who's
Hi, I'm a Marfan patient. I've had aortic root surgery. I'm suffering a little bit at the moment. I'm on losartan and I'm on bisoprolol. I'm suffering a little bit with a bit of asthma, sort of tightness of the chest at the moment. Not too bad, nothing really severe, but. So would you recommend if I monitored my blood pressure to maybe reduce or stop taking the bisoprolol?
That's a difficult one, Paul, without knowing the precise details of your heart issues and the sizes of the aorta and so on. I mean, probably what I would do first of all is try to improve the asthma with anti-asthma treatment with an inhaler. You may already be doing that, rather than stopping the bisoprolol. It would depend a little bit. I mean, what you could sometimes do is discontinue the bisoprolol or cut the dose down for a little while and see if the wheeze improved. But I would be cautious advising that without knowing the details.
Yeah, I understand that. Okay. But so could I actually? Do you think I'd be best requesting getting a different, you know, maybe Irbesartan or something like that?
The angiotensin receptor blocker will not have made a difference to it. Again, we don't know if they're synergistic, if they work better together. I have a feeling that they do, but we don't have the scientific evidence that proves that. They work in entirely different ways. So if I had a big aorta and I wanted to avoid surgery, I personally would go on both, provided I didn't have severe side effects. And it's a relative thing, really.
Okay, thank you.